If you are a person over the age of 60, what you are about to discover may come as a profound shock. The information I am going to share will likely alter your perception of the healthcare system forever. After conducting extensive interviews with hundreds of healthcare workers, seasoned physicians, frontline nurses, I have uncovered a disturbing and pervasive truth. This is the reality of what many doctors genuinely think when they are treating older patients. These are not isolated incidents or the opinions of a few bad apples. This is a systemic issue, a deeply ingrained cultural bias that is actively costing seniors their right to proper care, their dignity, and in the most tragic cases, precious years of their lives. One retired physician, who spoke on the condition of anonymity, referred to this phenomenon as the healthcare industry's worst-kept secret. It is a silent epidemic of prejudice that unfolds daily in examination rooms, hospital wards, and operating theaters across the country. You may have felt its subtle effects yourself, a sense of being rushed, a feeling of not being truly heard, or the frustrating experience of having your concerns dismissed. This is not your imagination. You are not being overly sensitive. What you are experiencing has a name: medical ageism. It is a powerful, often unconscious force that shapes every aspect of your medical journey, from diagnosis to treatment. The consequences of this hidden bias are far-reaching and deeply concerning. It means that legitimate, treatable symptoms are being overlooked. It means that life-saving procedures are being withheld. It means that crucial conversations about your health are being cut short or oversimplified. You are entering medical appointments at a significant disadvantage, unaware of the preconceived notions and economic pressures that are influencing the care you receive. But knowledge is the first step toward empowerment. You cannot afford to let another medical appointment go by without understanding what is truly happening behind the closed doors of the clinic or hospital. This information is not just important, it could be life-altering. Welcome to a special investigation brought to you by Senior MD, where we share health wisdom for older people. We believe that your golden years should be a time of vitality, respect, confidence, not a period of struggle against a system that should be there to support you. What you are about to learn today will fundamentally change the way you approach your healthcare from this moment forward. It will arm you with the awareness and the tools necessary to protect yourself, advocate for your needs, and demand the quality of care you rightfully deserve. The truths may be ugly, but facing them is the only way to reclaim control over your health and your future. Today, my mission is to pull back the curtain and expose 5 brutal truths about medical ageism that the healthcare establishment has desperately tried to keep hidden from the senior community. Think of this as your personal roadmap to understanding the challenges you face and, more importantly, how to overcome them. We will navigate this difficult terrain together step by step so you can emerge more informed and empowered. First on our journey, we will uncover the shocking mental shortcuts and snap judgments that doctors often make the very moment they see your age printed on a medical chart, long before you have even had a chance to speak a single word about your health. Next, we will delve into the disturbing economic calculations. You will learn how financial pressures on doctors and healthcare systems can lead to a form of rationing where your age, rather than your medical need, becomes a deciding factor in the quality of care you are offered. The third ugly truth we will confront is the dangerous and pervasive practice of filtering your symptoms through stereotypes. We will expose how legitimate medical concerns are frequently dismissed as just a normal part of getting older, a form of medical gaslighting that can lead to devastating delays in diagnosis and treatment. Following that, we will investigate the prescription practices that are specifically and disproportionately targeting older patients. You will be shocked to learn how medications are sometimes used not for medical necessity, but as a tool for behavioral control, making patients more manageable at great risk to their health. The fifth and final truth we will reveal is perhaps the most heartbreaking of all: the deeply ingrained assumption about your cognitive abilities. We will show how this prejudice directly impacts the quality of your diagnosis and limits the treatment options presented to you, creating a self-fulfilling prophecy of dependency and diminished care. But this is not just about exposing problems, it is about providing solutions. The most empowering part of our journey today is that for each of these 5 ugly truths, I will reveal the exact strategies that successful and proactive seniors use to flip these dynamics on their head. You will learn how to command respect, ensure you are heard, and secure premium healthcare. If you have ever felt dismissed, rushed, or talked down to by a medical professional, this video will equip you with the tools to ensure you never have to experience that kind of disempowering treatment again. This is your guide to becoming an empowered advocate for your own health. The moment you step into a medical office, long before you describe a single symptom, a silent and powerful process of categorization has already begun. The instant a physician or nurse sees your date of birth on the chart, your age triggers an immediate mental calculation in their mind. It is a deeply ingrained shortcut, a form of cognitive triage that healthcare professionals are trained to perform. In this system, seniors are almost automatically filed into the high-maintenance or resource-intensive category. This is not necessarily born from malice or a conscious desire to discriminate. Rather, it is a product of systematic programming that will inevitably color every single interaction you have from that point forward. Dr. Sarah Henderson, a former emergency room physician who has since dedicated her career to advocating for the rights of senior patients, revealed the unsettling reality of this training. Seniors are universally assumed to require longer and more complex appointments, a greater number of diagnostic tests, and intricate medication management plans. This assumption creates an unconscious bias, a subtle yet pervasive expectation of difficulty before the physical examination is even started, placing you on the back foot from the outset. This prejudgment shapes the very tone and pace of your appointment. A doctor who has mentally prepared for a complicated encounter may approach the conversation with a defensive or rushed posture. They might be quicker to interrupt, more focused on managing the clock than on listening to your full story. This is precisely what happened to Maxine, a 74-year-old retired librarian. She arrived at her appointment meticulously prepared. But before she could even finish her first sentence, the doctor interjected, saying, "Let's just focus on your main concern for today." Her attempt to explain the interconnectedness of her symptoms was met with an audible sigh and the dismissive phrase, "We need to prioritize." The devastating result was that Maxine's persistent chest pain was hastily brushed aside as anxiety. This led to a 6-month delay in a critical cardiac diagnosis. Her experience is a stark illustration of how the high-maintenance label actively obstructs the path to accurate diagnosis and timely treatment. You are no longer seen as an individual, but as a representative of a demographic that is inherently time-consuming and difficult to manage. This inherent bias against complexity is dangerously intensified by the brutal economic realities of the modern healthcare system. With insurance reimbursements steadily declining, and patient quotas constantly on the rise, doctors are trapped in a system that rewards volume and speed over thoroughness and compassion. They are often forced to see an unsustainable number of patients each day just to keep their practice afloat. This economic stress creates a direct conflict when treating older adults whose comprehensive health needs often clash with the doctor's severely limited time. This clash can breed an unspoken and perhaps even unconscious resentment that seeps into the quality of care you receive. Your legitimate need for a detailed discussion becomes a logistical problem for a physician struggling to stay on schedule. Research has starkly quantified this disparity, with studies showing that doctors spend, on average, a shocking 23% less time actively listening to patients over the age of 65, compared to younger patients who present with the exact same symptoms. This is not because your health matters less. It is because your perceived complexity represents a financial and temporal liability in a system that is stretched to its breaking point. Consider the doctor's perspective for a moment, not to excuse the behavior but to understand its origin. Each 15-minute appointment slot that extends puts them further behind schedule, creating a domino effect of delays and increasing their own stress levels. While a dedicated physician wants to provide the best care, the system they work within incentivizes them to find the quickest path forward. This often means focusing on the most obvious symptom, prescribing a standard medication, and moving on to the next patient on the list. This environment fosters a quick-fix mentality that is fundamentally at odds with the holistic approach that geriatric care requires. This economic strain transforms the doctor-patient relationship into a transactional encounter. These are not just signs of a busy day, they are symptoms of a sick system that prioritizes profit and productivity over patient-centered care. So, this aversion to complexity, it really goes far beyond just simple time management. It actually delves into the psychological burden placed on physicians, and it actively shapes their clinical decision-making. When they're faced with an older patient, they often anticipate a Pandora's box scenario. There's this real fear that ordering comprehensive tests will uncover a cascade of underlying issues. Each discovered issue might demand an extensive treatment plan, then follow-up appointments, and a whole lot of complex coordination of care. It is often easier to treat the most prominent surface symptom than to dig deeper and risk unearthing systemic problems. This kind of complexity aversion leads to diagnostic inertia. A younger patient with fatigue might get a full workup, but an older patient with the same symptom is more likely told it's just aging. Not because the doctor is certain, but because that avoids a potentially complicated investigation. This becomes a subtle but profound form of medical neglect. The potential for uncovering multiple issues becomes a deterrent to looking at all. The psychological impact on the patient is profound and deeply disempowering. When your provider views you as a difficult, costly problem instead of a partner, the foundation of trust begins to crumble. That dynamic makes collaborative treatment far less likely. Doctors often default to one-size-fits-all protocols for typical senior issues, even when those aren't appropriate. This mindset strips you of your individuality, your personal health history, your lifestyle, your treatment preferences. You're no longer John, the retired engineer who wants to hike, or Mary, the former teacher. Instead, you become the elderly patient with hypertension, or the senior with arthritis. This depersonalization is not just insulting, it's medically hazardous. It prevents the personalized care that's essential for navigating complex health in later years. One of the most pervasive and damaging forms of ageism you'll encounter in healthcare is the practice of polite medical gaslighting. This insidious form of dismissal has become so commonplace, so deeply woven into the fabric of medical communication, that many healthcare professionals often do not even recognize they're doing it. It occurs every time a doctor attributes a legitimate and potentially serious physical or mental symptom to the simple process of normal aging. When they do this, they're wielding a socially acceptable form of discrimination that serves to invalidate your experience, shut down further investigation, and, most dangerously, delay proper diagnosis and critical treatment.
The phrase "you're getting older" has become a medical cop-out.
Well, you are getting older.
It's become a convenient all-purpose explanation used to dismiss a wide array of symptoms that would trigger immediate and thorough investigation in a younger patient. This, as Dr. Torres emphasizes, is not evidence-based medicine. It is age-based assumption, and it is a betrayal of the doctor's fundamental duty to investigate. This gaslighting is often delivered with a veneer of kindness or sympathy, which makes it even more difficult to challenge. The doctor might say, "At your age, these aches are expected," or "we all slow down eventually." These phrases serve a specific purpose, to gently redirect the conversation away from a real medical inquiry and toward a passive acceptance of your declining health. They effectively close the door on your concerns by framing them as an unchangeable and inevitable reality of your chronological age. Let's be clear, while aging does involve physiological changes, it is not a disease in itself. Pain, extreme fatigue, cognitive changes, dizziness, persistent shortness of breath are not normal rites of passage. They are symptoms. They are your body's warning signals that something is wrong. When a medical professional dismisses these signals by blaming them on your age, they're failing to do their job, applying a lazy and dangerous label instead of engaging in the rigorous diagnostic process you deserve. This practice transforms your doctor from a curious investigator into a passive observer of your decline. The anecdotal evidence of this dismissive behavior is overwhelming, but the hard data is what really reveals the true scale of this crisis. The statistics are, to be frank, quite alarming. Groundbreaking research from the American Geriatric Society reveals a shocking truth. An estimated 85% of serious underlying medical conditions in senior patients are initially misattributed to the effects of aging before they eventually get a proper diagnosis. This is not a minor oversight, it is a systemic failure of epic proportions. For countless seniors, this initial dismissal means months or even years of unnecessary suffering. The pattern is, sadly, tragically predictable. Heart disease presents as profound fatigue. Treatable thyroid disorders become normal energy decline. Clinical depression is written off as a simple adjustment to aging. Most terrifyingly, the subtle early symptoms of many cancers are dismissed as normal aging: unexplained weight loss, persistent pain, changes in bodily function. Consider the real-world impact. Carl, a 67-year-old former construction supervisor. For 8 long months, Carl consistently complained to his family doctor about escalating joint stiffness and a level of fatigue. Each visit ended with the same frustrating, patronizing response. "Carl, you're not 30 anymore." It was only when Carl put his foot down and demanded comprehensive blood work that the truth was revealed. He was diagnosed with severe rheumatoid arthritis, an aggressive autoimmune disease that had been causing permanent, irreversible joint damage during those 8 months. This gaslighting also follows predictable, discriminatory patterns based on gender. Women often face a double whammy of discrimination. A woman's complaint of heart palpitations might be chalked up to anxiety or hormones. Meanwhile, men's complaints about declining sexual health or significant emotional changes are frequently brushed off as normal male aging, closing off conversations about cardiovascular health or treatable depression. In every case, the result is the same. The patient's suffering is prolonged and the window for early, effective intervention is slammed shut. Perhaps the most insidious and destructive aspect of medical gaslighting is, honestly, the profound psychological toll it takes on the person experiencing it. When a figure of authority repeatedly and confidently tells you that the concerning symptoms you are feeling are just normal, you inevitably begin to question your own perception of reality. You start to doubt your own judgment. You wonder if you are overreacting, if you are being a hypochondriac. This erosion of self-trust is not an accidental byproduct, it is the very mechanism that makes the gaslighting so effective. This induced self-doubt creates a vicious and dangerous cycle. The more your concerns are dismissed, the less likely you are to bring them up in the future. You may stop tracking your symptoms, you may hesitate to schedule a follow-up appointment. This delay in seeking further medical help is precisely what allows underlying conditions to worsen. The patient, now second-guessing their own instincts, becomes a passive participant in the neglect of their own health. This phenomenon is particularly damaging when it comes to mental health concerns. When legitimate symptoms of depression or anxiety are attributed to simple life stage transitions, such as retirement or an empty nest, it discourages seniors from seeking the therapeutic and medical support they need. They are taught to believe that feeling sad, hopeless, or anxious is a normal part of growing old. The message they receive is that their emotional well-being does not warrant the same level of medical concern as a younger person's. Ultimately, this process systematically strips you of your agency. Healthcare is supposed to be a partnership, but medical gaslighting transforms it into a paternalistic hierarchy, where the doctor's assumptions override your lived experience. You begin to feel like a child being told not to worry, rather than an adult partner in your own care. Breaking this cycle requires a conscious effort to reclaim your voice and re-establish the fundamental belief that you are the world's leading expert on your own body. Of all the hidden biases that plague senior healthcare, one of the most damaging and deeply insulting is the unspoken presumption of cognitive decline. This stereotype often dictates the entire course of medical care. Doctors routinely and unconsciously simplify their treatment explanations. They steer clear of complex or cutting-edge therapeutic options. They make critical medical decisions based on age-related stereotypes about intelligence rather than on an objective individual assessment. This is not about kindness or making things easier. It is intellectual condescension with profound consequences for your health. Dr. Amanda Richardson, a neuropsychologist, has dedicated her research to studying medical bias. She says providers consistently underestimate the cognitive abilities of patients over 65. They recommend simpler, often less effective treatments not because they're better, but because they assume seniors can't follow sophisticated regimens. This creates a self-perpetuating cycle of suboptimal care leading to poorer health outcomes. This prejudice is often subtle. It shows up as patronizing behaviors. A physician might speak in a slower cadence. They might use elementary vocabulary. They may give oversimplified explanations. A retired chemistry professor might be treated like they can't grasp basic science. That's offensive and medically dangerous. The assumption is automatic. The moment a patient is in their 70s or 80s, a mental switch flips. Doctors may skip crucial technical details. They assume you wouldn't understand or that details would only confuse you. That robs you of informed consent. It's a quiet theft of your autonomy, disguised as simplification. The real-world impact of this cognitive stereotyping extends far beyond just hurt feelings or frustrating conversations. It directly and materially limits the quality of care you receive. When doctors believe you cannot comprehend or manage complex treatments, they simply do not offer them. You are systematically excluded from discussions about cutting-edge therapies, innovative clinical trials, or more comprehensive diagnostic procedures. Instead of being presented with a full menu of options, you are given a default setting. The most basic, straightforward interventions that require the least amount of patient participation. Consider the harrowing experience of Louise, a 71-year-old retired chemistry professor. When she was diagnosed with an early-stage but aggressive form of breast cancer, her oncologist immediately recommended a simple mastectomy. He did not discuss advanced reconstruction options, targeted hormone therapies based on her tumor's specific markers, or enrollment in promising clinical trials. He explained his decision by saying, "At your age, we want to keep things straightforward and simple." Louise, with her sharp scientific mind, was left stunned. She had to fight for months, armed with her own research, to access the exact same state-of-the-art treatment protocols that were being routinely offered to younger women with an identical diagnosis. This bias is particularly dangerous when it comes to medication management. Healthcare providers frequently choose less effective drugs that have simpler dosing schedules, believing that seniors cannot handle the perceived complexity of managing multiple medications, prioritizing their perception of your ability to comply over the optimal medical outcome based on a broad, prejudiced assumption about your entire age group. Furthermore, this prejudice creates a significant barrier to modern healthcare through technology discrimination. Doctors often assume that senior patients are incapable of using health monitoring apps, navigating electronic medical portals. This assumption effectively cuts you off from a host of powerful tools. You are locked out of the benefits of 21st century medicine because of a stereotype. The cycle of cognitive prejudice becomes a tragic self-fulfilling prophecy when seniors begin to internalize diminished expectations. After repeated experiences, given dumbed-down explanations, and offered only the most basic treatment options, some older adults start to believe they're incapable of handling complex medical information. They lose confidence in their ability to understand their health, lose confidence to ask incisive questions, and lose confidence to participate as an equal partner in decision-making. This creates dependency and passivity, essentially manufactures the cognitive limitations doctors assumed. Treated as if not smart enough to understand, you may eventually stop trying to understand. This is dangerous. You become a passive recipient of care. Less likely to question a doctor's recommendation, less likely to seek a second opinion, and more likely to accept a treatment plan that may not be in your best interest. Proactive strategies are essential for your survival and well-being. Shatter assumptions from the very first medical conversation. Begin by briefly stating your professional background, state your educational history, or mention any relevant expertise you possess.
As a former project manager who handled complex budgets for 30 years, please feel free to give me all the detailed medical data I need to make an informed decision.
That immediately reframes the dynamic.
Ask for technical explanations using proper medical terminology. Ask, "Doctor, could you please explain the pathophysiology of this condition?"
And how each treatment option addresses the underlying biological mechanisms. If given an overly simplified recommendation, challenge it politely.
Ask, "What are the other, more complex therapies you might recommend for a 45-year-old with this exact same condition? I want to understand all of the available options, regardless of their complexity."
Forcing them to justify any age-based limitations. Now, we arrive at what is arguably the most disturbing and ethically questionable truth about modern senior healthcare. The way in which medications are systematically used as a form of behavioral control, rather than as a tool for genuine medical treatment. Healthcare providers are all too often prescribing powerful medications, psychiatric drugs, sedatives, mood stabilizers, to older adults. Dr. James Martinez, a former medical director for a large nursing home and now a patient advocate, has exposed this practice. "I have witnessed countless cases. Medications were prescribed not to improve a patient's health, but to reduce the staff's workload. Anxious seniors were given sedatives. Assertive patients received mood stabilizers. Those who asked too many questions were given antidepressants." Dr. Martinez calls this exactly what it is: chemical restraint disguised as medical care. The statistics are nothing short of horrifying. Current data reveals that over 40% of seniors in care settings are prescribed at least one psychotropic medication. Yet only around 12% have a formally diagnosed mental health condition that would justify these drugs. These are not benign sugar pills. These drugs come with dangerous side effects, increased risk of falls, severe cognitive impairment, even an increased overall mortality. This practice is a profound betrayal of medical ethics. Instead of taking time to understand root causes, a prescription is written to simply silence the symptom. The story of Beverly, a 69-year-old former school principal, provides a harrowing illustration of how this practice can spiral out of control. Following her hip surgery, Beverly became, understandably, frustrated with the slow and painful progress of her rehabilitation. She began asking her physical therapists, nurses, detailed, pointed questions about her recovery timeline and the effectiveness of her exercises. Instead of being seen as an engaged and motivated patient, the healthcare team quickly labeled her as difficult and anxious. The solution was not better communication, but a prescription for an anti-anxiety medication to help her relax. The consequences of this decision were devastating. The medication caused Beverly to experience significant confusion and severe balance problems. This led directly to a fall in her room, resulting in a broken wrist. While her original hip injury did eventually heal, complications from the unnecessary medication extended her recovery by 4 months and added a new layer of trauma. This use of medication for behavioral control extends beyond psychiatric drugs. Doctors routinely prescribe powerful sleep aids. Pain medications are often withheld. Perhaps the most insidious aspect is how these medications can create the very problems they claim to treat, trapping patients in a vicious cycle. For example, a sedative can cause confusion which then gets mislabeled as the onset of dementia. Mood stabilizers can lead to profound apathy which is then diagnosed as clinical depression. And sleep aids can disrupt natural sleep cycles, creating a medication-induced sleep disorder that requires even more medication to manage. We now arrive at the most heartbreaking and morally corrosive reality in senior healthcare, a truth so deeply unsettling that it is rarely spoken aloud. This is the practice of calculating your life's value when making critical treatment recommendations. Behind the closed doors of hospital administration meetings, insurance company boardrooms, and even in the subconscious minds of physicians, cold economic formulas are being used to weigh the cost of your treatment against your projected remaining quality life years, resulting in seniors receiving demonstrably inferior care. Dr. Patricia Chen, a respected ethics professor, reveals this shocking truth. She explains that modern medical training and health economics include concepts like QALYs, or quality-adjusted life years. This system essentially assigns a numerical value to different lives and different states of health. Under this framework, a year of healthy life for a 70-year-old is calculated as being inherently less valuable than a year of healthy life for a 40-year-old. This cold calculus then directly influences everything from organ transplant eligibility lists to cancer treatment recommendations. It is systemic mathematical age discrimination disguised as objective medical economics. Seniors are routinely and quietly denied access to expensive procedures, cutting-edge therapies, and aggressive life-saving treatments. Consider, if you will, the powerful and infuriating experience of Walter, a 68-year-old retired engineer. When he was diagnosed with end-stage kidney failure, his medical team immediately began directing him toward palliative and hospice care. They gently suggested that dialysis might not be appropriate at his age. Walter, an engineer who understood systems, recognized the flawed logic. He had to fight relentlessly for 3 long months to access the exact same treatment that is routinely and automatically offered to younger patients. The fight was worth it. After starting dialysis, he returned to a full and active life, enjoying 7 more productive years the system was ready to deny him. This discriminatory calculus is not limited to life or death treatments. It also extends to the diagnostic procedures that are crucial for early detection and prevention. PET scans, specialized genetic testing, routine preventive screenings, are often implicitly or explicitly denied to seniors. This is based on cold actuarial calculations. Insurance companies and large healthcare systems frequently use age as a primary cutoff factor. Their internal logic assumes that older adults will not live long enough to reap the long-term benefits of early detection, creating a dangerous policy of waiting for a disease to become advanced and untreatable. Mental health treatment receives particularly harsh and cruel age-based rationing under this system. Legitimate, treatable conditions like depression and anxiety are often dismissed as natural, unavoidable responses to the process of aging. Psychological therapy, ongoing psychiatric care, and modern mental health medications are shockingly considered wasteful. The emotional and psychological suffering of seniors is effectively devalued. The tragedy of this systemic devaluation deepens significantly when seniors themselves begin to internalize these harsh value judgments. After hearing repeatedly that they are not candidates for the best care, Many seniors start to believe that their lives are, in fact, less worth saving. They stop advocating for themselves with vigor, they passively accept substandard care recommendations, and they make critical end-of-life decisions based more on society's devaluation. They are subtly convinced to give up by a system that gave up on them first. This discrimination becomes particularly cruel and manipulative during discussions with families. Healthcare providers can subtly influence families to choose less expensive, less aggressive care options. They skillfully frame these limitations not as rationing, but as comfort measures or more age-appropriate care. Families are encouraged to consider the supposed burden of aggressive treatment, without ever being given a clear and honest picture of the full range of available options. They are guided toward a decision that serves the system's finances, not the patient's life. You now understand the 5 ugly truths about medical ageism that the healthcare establishment never wanted you to discover. The systemic biases are real and deeply entrenched. But here is the crucial takeaway that changes everything. Knowledge is power. You are no longer an unaware participant in a flawed system. You now possess the critical awareness and the specific tools necessary to transform every future medical encounter. You can shift the dynamic from being a passive patient spoken down to and managed, to becoming an empowered advocate who commands respect and participates fully in your own care. Remember the stories of resilience. Think of Walter, remember Beverly, and recall Louise. These are not exceptional, once-in-a-lifetime cases. They are powerful examples of what happens when seniors refuse to blindly accept discriminatory treatment based on their age alone. Every single time you challenge an age-based assumption, every time you demand a more detailed explanation, and every time you advocate for comprehensive care, you are doing more than just fighting for yourself. You are actively helping to dismantle a prejudiced system. Your assertiveness creates powerful ripple effects that benefit every older adult who comes after you, teaching doctors and administrators that seniors will not be passive recipients of inferior care. The medical establishment may hope that seniors will remain quiet and compliant, but you are different now. You recognize the biases, you understand the discrimination, and you possess the strategies to overcome both. Your health, your dignity, and the precious years of your life are far too valuable to surrender to age-based prejudice. The journey to transform your healthcare experience starts today, with your very next appointment. You deserve medical treatment that is based on your unique, individual health profile, not on lazy stereotypes about your age group. Your life has immeasurable value, and you have the right to demand that it be treated as such. Go forward with the confidence that you are not just a patient. You are the most important member of your healthcare team, and your voice must be the one that is heard the loudest.